past 8, and we are delighted to have Dr. Megan Prochaska from the University of Chicago talk to us about stones. Chicago is stone central, as we were just chatting before. So Dr. Prochaska did her undergrad and medical education at the University of Chicago and residency training as well. And for nephrology fellowship and an additional research fellowship, she went to Brigham and Women's in Boston, which is where we made the connection with Greg Hundemer, who introduced us to her. After working briefly as an attending in Boston, she moved back to the University of Chicago, where she's an assistant professor of medicine. She seems to have a big stone practice as well as a general nephrology practice, and she'll talk to us about the medical management of kidney stones. Thank you.
Yeah, thank you so much. And thank you very much for having me. Thank you, Greg, also for getting me connected. Yeah, so the title of my talk is Medical Management of Kidney Stones. When I was debating, how research versus clinical to make this, I decided based on, thinking through who the audience would probably be, to make it a little bit more of a clinical talk. So it really is predominantly a clinical talk. I will touch on some of our more recent studies. I'll, where I remember, I maybe even mention some of the ongoing research studies that we have. But for those of you who are interested, of course, I'm very happy to talk about some of our ongoing research studies as things come up and if you have questions about that. So let me get so my slides can advance. There we go. Okay. So to set the stage, I'll start by reviewing some of the epidemiology of kidney stones and, of course, review a basic workup. But I want to spend the majority of time talking through some of the medical management strategies that we do and sort of trying to describe or demonstrate the approach that we take when it comes to managing common kidney stones. So kidney stones are incredibly common. I think this group well knows that and probably is seeing increasing numbers of referrals. It's because prevalence is also on the rise. This 8.8% lifetime is the U.S. estimation from NHANES data where the data went up to 2010. So it's pretty, it's nearly 15 years old data now. And at the time when it was estimated, when you compared it to the previous estimates, it had been every single time it had been on the rise. And so it's expected that trend has continued. And so certainly today in 2023, the lifetime prevalence is certainly higher than 8.8%. And recurrence rates are also high. So about 30 to 50% of patients, once they have a stone, they'll have a recurrent event. Stones are incredibly costly. So in terms of US dollars, it's estimated that it's billions annually. What goes into that number, of course, is going to be ER visits and patients go in pain. They need to get their pain managed, and that often requires the emergency department. It can be scary for patients to have hematuria for the first time, or even if they know what's going on, it still can be a scary experience that often brings them to the ER. And then repeated procedures. So a lot of these stone patients have multiple ureteroscopies and lithotripsies and other things throughout their lifetime that add to this money as well, or add to this cost as well, plus lost work wages, as they typically need to be out of work for a couple days at a time. So to remind you, stone type calcium oxalate stones are going to be the most common stone type for all folks, but there is a difference as we age by sex in terms of what the most common stone type is. So for men, across all decades of life, it's going to be calcium oxalate stones, but once men get into their 50s, then uric acid stones become a little bit more common and become the number 2 most common stone type that they see. For women, it's most often calcium oxalate as well, except for these younger women in their 30s where calcium phosphate stones become briefly more common. And so when we're reviewing a patient and trying to understand what are their individual clinical risk factors for developing stones, of course, having a history, a personal history or a family history of stones is a strong risk factor. I just mentioned recurrence rates. People with systemic conditions that are going to increase the enteric absorption of their oxalate. So these are going to be Crohn's disease patients. We have a lot of IBD patients in our clinic, patients who have had malabsorptive bariatric surgeries like Roux-en-Y gastric bypass. They're going to fall into this category. In fellowship, one of the papers I did showed that patients who had a history of low bone density were also at a higher risk for developing stones, and you'll see bones are going to keep coming up when it comes to the kidney stones. Obesity, diabetes, gout, hypertension, these are for very important risk factors, notably, especially the obesity and diabetes, very strong risk factors for kidney stones. When you look at the epidemiology, the point estimates are incredibly high for both of these, obesity and diabetes. And probably when we think about, okay, why is prevalence on the rise for stones? It's probably multifactorial, but among them is definitely going to be the fact that obesity and diabetes are also on the rise. And of course, there's been a number of important dietary risk factors that have been well described. So we care about kidney stones as nephrologists because we want to prevent them to avoid, some of that acute morbidity that I already described. But it's also really important because our patients who have stones are at a higher risk for developing subsequent bone fracture. So both associations have been shown to be true in terms of kidney stones and bones, which highlights what a lot of stone folks say is that a kidney stone clinic is also a bone clinic, and also highlights the fact that kidney stones are a systemic condition, and they are definitely, under that category of disorders of, mineral metabolism, which is why it's, kidney stones and bones go so intimately together. Hypertension, CAD, CKD, and ESRD are also, our stones are at higher, our stone patients are at higher risk for developing these conditions as well. So, a huge number of our patients fall into this category in terms of, their cause of stone formation being idiopathic. Can't necessarily identify a systemic disease, although when we do a deep dive, as nephrologists love to do, we can often find some sort of underlying, depending on how subtle, metabolic derangement. A growing group of our stone patients are the genetic diseases. So classically, cystinuria, primary hyperoxaluria, now there's 3 types of pH that have been described. Those are some of the more classic genetic conditions. But as we get better as a medical field in terms of, having these large panels where we are a little bit more commercially available to test for some of the different genetic diseases that have been described, more and more of our idiopathic patients are falling into this genetic diseases. And this is Fred Coe, who's my mentor. Some of you may know Fred or may know his work. Fred's very into now, getting more and more gene panels on our patients and trying to better define these folks who fall into this category. And of course, then the acquired diseases. We talked about bowel diseases and primary hyperpara as well. So who do we want urology to send us, and who, primary care, who should they definitely be sending us? And of course, the short answer is recurrent kidney stone formers. Just to show you the data to really emphasize why that's important, recurs, definitely recur. And so the patients who have had a single stone, this is data out of the Mayo Clinic, yes, by the time they're 25 to 30 years out, the probability of recurrence is around 0.5. But when you look at patients who have already had 3 or 4 stones, by the time they're hitting, even 5 years, their probability is maybe greater than 0.6 in terms of recurrence. Now, there's probably something different about some of these patients, right? So more of these patients are going to have genetic diseases. More of them are going to have more severe systemic conditions that are putting them at higher risk. But for those reasons, those are the folks we're going to want to see because they're very high risk to recur. And then, of course, even if they've only had a single stone, if they've had a single stone but only have a solitary kidney, we're going to want to be aggressive with those patients as well. I actually have a patient I'm seeing later today as a new consult who falls into this category. I'm going to want to be very aggressive with her management because certainly the last thing I would want is a stone to obstruct her single kidney. Okay. So, this is maybe my what we're doing is worthwhile slide. This is my encouraging slide. Keep at it, even though sometimes it can feel discouraging. This is I thank Elaine Worcester, my other mentor, for this for this slide. So what she did was she took this data here has been published. This was published by Fred and Joan Parks, one of his longtime colleagues, about 15 years, or almost 15 years ago by now. And these are the recurrence rates, are essentially the fraction without relapse for patients who are actively being followed in our University of Chicago Kidney Stone Clinic. And so they were getting 24-hour urines, they were seeing nephrologists, they were having individualized plans that were tailored to them for stone prevention. What Elaine did, and what this line represents, was she took all of the clinical trials that included recurrent kidney stone patients, and she looked at the control arm, so the patients who in those trials were not getting any active therapy, and she plotted their relapse rates right here. So the patients who are recurrent kidney stone patients but don't get directed active management by a nephrologist, they recur incredibly quickly, nearly 50% by the time they're at 5 years. And so even though, yes, you can see that a lot of our patients in Stone Clinic, yes, they do have recurrence, and a decent number of them by the time we're 25 years out, these patients certainly do much better than the patients who aren't getting active treatment. They're going 5, 10, 15, 20 years before they're having a recurrent event. And so they're having fewer of them over their lifetime. And certainly all of us would probably prefer to be on one of these lines than this line. How do we do it then? And that's what we're going to talk about. Is, I'll try to describe to you or show you our strategy today or our approach today. So, targeted with fluids, dietary advice, medications when needed. So for the first time I see a patient like this young woman I'm going to see today, my appointments are really long. So I take a very thorough history. I get details of their occupation in the sense that, do you have access to water throughout the day? Do you have access to a bathroom throughout the day? That helps me not just assess what got us here to begin with. Was fluid intake contributing to why they formed their stone? But it's also helpful for me to know, because if adjusting their fluid intake is going to be a part of my management strategy, I'm going to need to take into account that they're a long-haul truck driver, and maybe stopping to urinate every 2 hours is just not feasible for the individual. And then, of course, I take a pretty thorough diet history on everyone. So yes, we get a stone analysis, screening blood tests. Some of these are pretty straightforward. UA and imaging is often helpful when I first see people, just so I can at that point, when I first start the prevention, get an idea of what their stone burden is. But really, we were talking about this earlier before I started, but our bread and butter, what we spend all of our energy, effort talking about, both in clinically with our patients, but then also from a research standpoint, is our 24-hour urines. So we, and this is one of the things we were also talking about earlier, for our patients, we're able to assess measure all of these things in a single 24-hour urine collection, and we get a calculation for, then with that, we calculate a supersaturation. So for that reason, for every single one of my patients, the first time I see them, I have them get at least 2, but ideally 3 24-hour urine collections. And of course, this is because I want to capture more with in-person variability. For our patients who work Monday through Friday, 9 to 5, their urine composition may look very different on Monday versus Sunday. And I'm going to want to capture more of that data if possible. And that's how I help, sort of describe that to patients, is to maybe help motivate them to do a test that's not necessarily the easiest test to do. But with that, how do I break it down for patients? How do I help them understand their urine composition when I'm sitting there in clinic? So really what we start with, and how I start by helping a patient understand their own urine composition, and then from there going into their plan, is with the supersaturation. So I understand you guys aren't able to have supersaturations on your urine compositions right now, but the reason why we like to start there is because for us, what it is, first of all, for those of you who are less familiar, is it's a calculated number. It uses, we use equal to. Litholink and other common labs often also use equal to, which is an iterative computer program to calculate it. And what goes into that calculation are a number of measured things. So for calcium oxalate, it's going to be the volume, the calcium, the oxalate, and the citrate. For calcium phosphate, the phosphorus and the pH come into play, and uric acid is really pretty much solely driven by volume and pH. So what I do and how I translate all of this to my patients is I tell them that the supersaturation they can think of as their risk number. So I describe it as a risk number because we have been able to show that that's the case, and so for that reason, it can be a good starting point. So this is data that I published as I was finishing up fellowship. So we took urine composition from the Nurses' Health Study 1 and 2, which are both female cohorts you may be familiar with. The Health Professional Follow-Up Study is a male cohort, so this is men and women. And I looked at what the relative supersaturation was for these people and the odds then of them being a kidney stone former. So this is incident kidney stone, so we do make some extrapolation and to apply it to recurrence as well. But what we found was that as the level of supersaturation was higher, their odds of being a stone former was much higher. So when I'm seeing a patient in clinic and their supersaturation's up here, I can tell them, okay, you have a very high risk, you are at very high risk of forming a new stone, or any stones that you have, they're getting larger. So then I say, okay, but what does that mean? What next? Then what we do is we break down the supersaturation by the components that drive it. So for that patient, I might say, okay, so now what we're going to do is look at your volume, calcium, oxalate, and citrate, and see of those four things, what is the major driver of your supersaturation? And from that, I can say, what's the driver of your stone risk? And then we develop a plan targeted really at the main drivers and the main contributors to their stone risk. So we'll try to do that. I'll try to sort of show that approach now. This case I've simplified a little bit in some ways for to demonstrate what we do. But this is a gentleman I saw about 2 years ago, and at that time he had a history of recurrent stones. He had passed one spontaneously, but he had required ureteroscopy urgently before. He didn't have any other glaring obvious risk factors, and this is a very much abbreviated version of the dietary history I took on him, but just to sort of demonstrate, he in some ways has what a lot of our typical, American and potentially also Canadian diet looks like, which is fast food throughout the week because he works going out to job sites and so grabs, a burger and fries. Eats at home about half the time throughout the week, and typically then it's going to be a beef with maybe a veggie. So we started with him, and these are his supersaturations. And again, for simplification, I'll really just focus on calcium oxalate. That's the type of stone he had formed. So this is a supersaturation of calcium oxalate. And so to orient you, each row then is going to be correspond with one of his collections. So he did 3 urine collections for me before I met him. And so the goal supersaturation for calcium oxalate is going to be 4 or less. So he's at high risk. Certainly he's at quite high risk on collection day number 3, and even really you could argue quite collection day number 2, maybe a little bit more moderate on day 1, but still he's at high risk. So then we'll break it down. All right, what is driving up the supersaturation for him? And we'll start with his volume. So he did have low urine volume, at least on one of those days, but let's talk about how does volume play a role in this? What is the data that we use for in terms of urinary volume? So this part's pretty obvious. This group well knows, it's a driver of supersaturation. Lower urine volume has been independently associated to be associated with higher kidney stone risk. This is also using nurses' health data, health professional data. Here's really quite high risk for the low urine volume. And of course, it's protective then to have high urine volumes. So if we want to increase the urinary volume to decrease the supersaturation, decrease the stone risk, how do we modify this? Well, this is also, quite obvious to this group. We increase their fluid intake. And this is also a place where we actually do have clinical trial data. We don't have a ton of clinical trials in kidney stones, but this is one of our landmarks. So Dr. Borghi and his group in Italy did this study, back in the 90s. And they had patients who were on a high fluid intake to achieve a high urine volume versus usual care. And pretty much right away, there's a split of these two groups. And the patients who achieve the higher urine volume have fewer recurrent events. And they also had a much lower supersaturation at the end of the study, too. What about in real life? How does, does this work for our patients in real life? So this data is kind of old, but I think it still demonstrates the point, and also the theme that I see in this data comes up a lot in some of our other more recent studies. So I like this figure. But what this is, all these individual dots are patients from the University of Chicago Stone Clinic who had been seen. And what Joan, who was the first author here, what she did was she plotted what their urine volume was before they were seen in clinic and what their change in urine volume was after they were seen in clinic. So not surprisingly, the people who started with quite low urine volumes, they were able to increase their urine volume by nearly a liter. And of course, that's going to trickle off for the people who started with higher urine volumes. They're going to increase it less. Makes sense. Either, probably a mix of things. The clinician's going to spend a lot less effort talking about urine volume if they're already up at a urine volume of 2.5 liters. And there's also probably a threshold at which most patients just can't go too much higher in terms of fluid intake. I will say that some of my patients surprise me by coming in with urine volumes routinely 3.5, 4 liters, but most people it's not quite that high. So yes, and this is going to apply to every single one of our stone patients. We aim for 2.5 liters per day. And then obviously we're going to avoid fluids that are high in salt and sugar, as both of these things can increase urinary calcium excretion. So with that, then let's move on to calcium. So he has pretty high urinary calciums, really high day 2, but also above goal even for days 1 and 3. So Calcium, of course, is a major driver of both calcium oxalate and calcium phosphate supersaturation. And independently, higher urine calcium has been associated with higher stone risk. So we know that lowering the urinary calcium is going to decrease the supersaturation. It's going to decrease stone risk. But how can we modify this with diet? What do we do with the dietary calcium intake? So this is, even though the data on low calcium diet really goes back into the 90s, showing that low calcium diet actually increases stone risk, I still always talk about this in my talks because even last week I had a patient come to me who was told to be on a low calcium diet. So despite the fact that we're now a couple decades into pretty strong data against a low calcium diet, it still seems to persist. So I think it's still helpful for us as nephrologists to talk about because of what we're going to see in a second, that woman absolutely should not be on a low calcium diet. So to remind you, why does low calcium diet actually increase stone risk? And to show you, first of all, what that risk looks like, this is predicted probability from some recent data out of the Mayo Clinic, but it shows again where that sweet spot always seems to be, that around 1,000 to 1,200 milligrams per day of calcium intake is really where the lowest risk of stones seems to be. And it really jumps up quite rapidly when we go calcium intakes lower than that. Now, certainly it is possible to have too much calcium. And so I don't want them to go overboard with their dietary calcium intake, but we try to aim for right here. And why is that the case? Well, a low calcium diet actually raises urine oxalate. How does it do it? Again, you can see that this is that same sweet spot of calcium intake, around 1,000 to 1,200 milligrams per day. And as we go lower than that, the percent of the oxalate that is absorbed in the gut goes higher. And so this then, the oxalate that's absorbed in the gut ends up going to the urinary oxalate, and this is then what drives stone risk for these individuals. But also, separate from the fact that it raises stone risk, we're putting these patients, if we put them on a low calcium diet, we're putting them at risk for bone disease and fracture. And this is, pretty straightforward. If they have a set point for whatever reason in terms of idiopathic hypercalciuria, if they're always going to have elevated urinary calcium levels, and then we put them on a low calcium diet, they could end up being in negative calcium balance for, who knows how long. And that's, of course, where does that calcium come from? But our bones, which is, as this group well knows, where 99% of our calcium is stored. And so that's why we definitely want to get these people. That's why that young woman who I saw, one of the first things I said to her is, we need to stop your low calcium diet. Please add some yogurt into what you're eating. So, and we have clinical trial data that demonstrates this as well. So this is Dr. Borges' second big clinical trial that really is our second major landmark trial in stones. This was published in the New England Journal now 20 years ago. And so what they did was they put people on a low calcium diet defined as 400 milligrams, and then a normal calcium diet defined as 1,200. And, I'll also say the caveat, of course, of this trial is that they didn't completely isolate normal versus low calcium diet. These patients were also on a low salt diet, and what they described as a low protein diet, although dietitians may argue that this is not exactly low protein, but in the 90s when this was being developed in Italy, that was maybe part of that definition. But once we hit 3 years, there's a pretty clear separation of these lines, and the low calcium group has a much higher incidence of recurrence compared with the low calcium, or the normal calcium group. And when you look at the urine composition between these two groups at the end of the trial, the group who was on the low calcium diet, the only difference in their urine composition was that those patients had higher urinary oxalate. So it really did seem to be that the mechanism here that was driving the stone risk for these patients was the mechanism that I described. And that was despite the fact that they had similar oxalate levels in their diet. So that's why the AUA, the American Urological Association, their guidelines are 1,000 to 1,200, and that's what we follow then. So just to show you some of the bones and stones data, again, maybe just to really hit it home that these patients are at higher risk for bone disease. This is older data, so a lot of these patients are going to have been on that low calcium diet, where patients who had stones had 4 times greater risk of fracture. But even more recently, when this was updated, a C. Jason paper from 2014, for men, the overall relative risk for across their lifetime was 1.13. So not hugely high, but also we don't necessarily worry so much about bone disease in a lot of our men, so it's not insignificant. And for women, that varied a little bit throughout the decades of life, and it was highest then for the younger women in their 30s, where the relative risk was as high as 1.55. Okay. So, all right, so we definitely don't want to put them on a low calcium diet, but what can we do to lower their urinary calcium? Well, so this is really where our salt intake comes in. So to remind you all, when we eat dietary salt, what happens is that sodium goes into the proximal tubule. This is going to decrease the proximal tubule drive for reabsorption of calcium, and so that's why the urinary calcium stays higher. And this is not published data formally, but this is a figure that I really like from Fred Koh's website. And what Fred did was he took patients so in red are non-kidney stone forming patients. And this is their urine, plotted their urine versus their calcium for these non-kidney stone patients. And you can see that, yes, as the sodium goes higher, so does the urinary calcium. For the blue, these are kidney stone patients from different studies, and he did the same thing, but you can see that the effect of this is even more pronounced. It's even more exaggerated for our stone patients. They're going to have much higher calciums even for some of the same levels of sodium, really emphasizing how important it is for our stone patients, especially if they're hypercalciuric, to be on a low salt diet. And that's why time and time again, every single time this is looked at epidemiologically, low salt diet, DASH diet, Mediterranean diet patterns, all of those have been associated with lower risk of stones. And we use then the AUA guidelines of 2,300 milligrams per day of dietary sodium to help our patients. And just real quickly, this has also been looked at. Sodium has been isolated in a very small trial amongst recurrent stone formers. This is also the Italian group. They put patients just on a low salt versus control diet for 3 months. So they couldn't look at recurrence, but they did have urine data. At the end of the trial, the low salt group did achieve a lower urinary sodium, and this did translate to a lower urinary calcium. So we can extrapolate from this, that the risk for these patients was going to be lower for forming additional stones. So it does work in a trial setting as well. What about in the real world? All of us, for stone patients, but also for our CKD patients, our hypertensive patients, those of us who are clinicians probably talk about low salt diet at least once per clinic. But how we know that it's not easy for our patients. So how does it translate in the real world? This is a paper that we just published last year. Joey he was one of our undergrads. He's now a medical student who did some work with us. And what he did was we had him take a look at some of our idiopathic calcium stone forming patients. And we get 3 urine collections before we see the patient. And then we had him look at that first initial visit, what type of advice did they get? And for the people who received low sodium diet advice or advice to be on a low salt diet, they started with a higher urinary sodium level and a higher urinary calcium level. That's not surprising, sort of describes what we would expect in terms of a practice pattern. And then we had Joey look at the 24-hour urine collection that they did after they received that advice. And even though you can see the spread is certainly a lot wider here, the variance is much wider here for the sodium, the change in sodium, they were able to successfully lower their urinary sodium by 28 milliequivalents per day. Not a huge dramatic amount, but that did translate to a reduction in their urinary calcium by about 75 milligrams per day, which can be impactful in terms of stone risk. So I just say that, small changes can make some impact, and, this is first time single follow-up. I think frequent follow-up, our dietitian support, all the different strategies that we use for our CKD patients can apply here too, just to try to continually reiterate to our patients how important this is, and hopefully with longer time we can make even more impact for that. Okay, and you can see here for our, it's not completely straightforward, but for him, on days he had a higher sodium intake are going to be the days where his urine calcium was also the highest. So it's really important for him to reduce his sodium intake for this patient. All right. What about pharmacologic strategies? So thiazides, of course, this is where we, most of our patients are going to be on thiazides in the end. I always start with dietary stuff first, but it's not uncommon for me after someone has maxed out what they can from a low salt diet is to add on a thiazide. So this is the data showing that these are the 3 kind of main trials of the different thiazides we tend to use. These days I'm mostly using indapamide, but Fred's typically still going for chlorthalidone. None of us really use hydrochlorothiazide anymore because of the BID dosing, but in the trials, all of the treatment arms did much better from a relapse rate compared with the control arms. Okay. And, what about the combination of those two? So this was from that same paper that we had Joey work with us on. And so we had them take a look, okay, what about the patients who were told to be on a sodium restriction and prescribed a thiazide? Well, so we can see here that, in this group, the people who, this is the urinary calcium levels for those who were given both of those therapies. And you compare it here to the people who were not given either of those therapies. Of course, at the urinary calcium level is much higher. Those people got progressively more interventions. Over here is then the change, or the delta calcium, and the people who didn't get any therapy, of course, didn't budge their urinary calcium, not surprising, but those who received both therapies did actually have the greatest reduction in their urinary calcium, and then just receiving one of the two moved the needle a little bit, but certainly the largest change was with the group that received the dual therapy. And so, not surprising, the effects may be additive. Okay. So let's change gears a little bit to talk about oxalate. Of course, also a major driver of calcium oxalate supersaturation, and also independently, higher oxalate has been associated with higher stone risk. So where does our oxalate come from? I think this is always kind of a good reminder. A huge amount of our oxalate, of course, is going to come from dietary oxalate, and from there, the percent that gets absorbed by the gut. So spinach is our classic example of a high oxalate food. It's going to be here in the gut lumen, absorbed both paracellularly and transcellularly via channels. SLC26A6 is the classic group of transporters for oxalate. But then, and I'll also say here that people who have, who don't have any malabsorption, no issues with their gut, they typically absorb about 5 to 15% of their dietary oxalate. That's going to go up when you have malabsorptive states like Crohn's disease, for example. And then there's the second part of our oxalate is going to come from endogenous production. So those two sources together make up the oxalate that we measure in the urine. And of course, when I'm looking at someone's urine oxalate, I can't tell which of these two sources it's coming from. But if someone has or if I'm suspecting primary hyperoxaluria, I'm going to assume that it's an endogenous production. If they have something where I'm concerned about their gut or something I've screened for in dietary history, then I might assume that it's from this source. And I'll also say that although I leave the liver picture on here for endogenous production, more and more data is showing us that the liver is not the only organ that actually produces oxalate. And there was a couple of really nice talks that touched on this at ASN last year. The UAB group is really some of the leaders in that right now. So those of you may know Dr. Mitchell down at UAB. She and her group with Ross Holmes is retired, but John Knight, they've done a lot of that group show. I still leave the liver because it's sort of classically thought of as liver, but probably there's a lot of other tissues that also produce it. But so with all that though, does modifying the diet, does lowering the dietary oxalate intake, does it actually lower our urine oxalate? The answer here is yes, but it's also a little bit of a caveated maybe. So one thing just simply is, this is some epi data from the Nurses Health Study and the Health Professional Follow-Up Study. And in the quartile of dietary oxalate intake, the highest quartile of dietary oxalate intake, those patients did have, or participants did have, the highest urinary oxalate level. So that's consistent. But it may also depend a little bit in terms of who you are. So this study was a group of idiopathic stone formers. And I think this was a 3-month trial as well. And what they did was they put patients either on a low oxalate diet, supplements, which were B6 and magnesium, or the diet and the supplement together. And at the end of the 3-month trial, they did, fortunately, the patients who were on the low oxalate diet did have a reduction in their urinary oxalate. Of course, the caveat here is that when the two dietary arms, or the two arms that included diet, only about 55% of people made it to the end of the trial. So they had a really large dropout. There was about similar in the 70s in terms of the percent of people who were able to last to the end in the supplement only arm. So yes, it's maybe hard to follow, but the good thing is that people who can follow this diet, they can potentially lower their dietary oxalate, lower their urinary oxalate quite meaningfully. But it may also depend on who you are, because this is also some data out of our clinic. And so Juliana was one of our other undergraduates who worked with us. And similarly, Juliana looked at that first initial clinic visit. She took patients who were just bowel disease. So these are Crohn's disease patients, bariatric surgery patients. And the patients who, amongst that group of people, were told to be on a low oxalate diet, and those were not. That's what she looked at, who were told to be on a low oxalate diet. The open squares are the oxalate levels for those who were not told anything about oxalate diet, and their closed squares, that, the line that's superimposed right on top of it, those are their oxalate levels in follow-up. They didn't change their oxalate levels, not at all surprising. The open circles, however, which are, higher oxalate levels anyway, those people were told to be on a low oxalate diet. And in follow-up, their closed circles, again, superimposed right on top of it, show that despite being, counseled to be on a low oxalate diet, they did not budge their urinary oxalate levels. So potentially we didn't do a good job counseling them, or it was difficult to adhere to, or maybe there's something different with their underlying physiology. Answer to part of that was this study where they took 6 patients who had Roux-en-Y gastric bypass. This was in the Mayo Clinic. They put them on a low oxalate diet in the CRC, so they knew they were getting the diet, they knew that they were actually eating it, and despite that, before and after, they didn't change their urine oxalate levels at all. So this is one of the places where we have a study. We're just about to start enrollment. We have approval from the IRB and all that now, where we're going to try to look at better understand, use things like labeled oxalate to better understand how much of this is absorbed for these bowel disease or actually in some obese patients too. So we have a couple of different populations we're going to look at to try to better understand this so that we can identify, because certainly there are some people who benefit from a low oxalate diet. We want to help identify the people who would benefit, but not, the people who aren't going to benefit much from a low oxalate diet. We don't necessarily want to spend a whole lot of energy trying to get them on a low oxalate diet when it may not get what we're, our anticipated effect. So this is one area where we have a study that we're about to start. Okay, switching gears then again to talk about citrate. This gentleman had very low citrate in all 3 of his collections. So why is citrate important? Again, it's a chelator of calcium. So in urinary space, calcium and citrate form a soluble complex, so this stays in solution. We can urinate it out, decreases how much calcium is available to bind with oxalate, which of course does not form a soluble complex, instead forms a crystal in a stone. And so for this reason, citrate is a major driver of supersaturation, and we really want our patients to have high urinary citrates. High citrate is going to be protective. Low citrate has been associated with higher stone risk. So how do we do this with diet? Well, this is where we're going to definitely push our fruits and vegetables for our patients. The Italian group did this. They took idiopathic kidney stone patients and they just gave them fruits and vegetables. And they then measured their urine composition as they were supposedly eating these fruits and vegetables. And you can see that the patients who were in the trial, they did have an increase in their urinary citrate while they were eating these fruits and vegetables that are being given to them. Now, you can also notice that there's also a lot of dropout. So by the time we get to the end of the study, there's 2 poor little souls who actually made it. But the good takeaway is that it is effective for those who can do it, or for those who do it. And the patients who stuck around, or for while they, even these people, while they stuck around, their supersaturations were much lower. So their risk of being a stone former or forming additional stones was much lower. So that is why our take home to all of our patients is you need to eat your fruits and veggies. I also need to eat my fruits and veggies. So, okay. What about pharmacologic strategies? Of course, of course, this is where our potassium citrate comes in. We prescribe obviously a whole lot of potassium alkali in our group, or alkali in general in our group. These were 2 of the big trials that really looked at that, and of course the percent of relapse was much better in the treatment arms for people on alkali compared with the control arms. So I wanted to say a quick word. How are we doing on time? Good. I want to say a quick word about uric acid stones. So really, when it comes to uric acid stones, of course, we start by trying to identify causative factors, and a lot of this is going to be GI disease. So a lot of our, certainly our patients who have GI disease, they're also at risk for calcium oxalate stones, but their risk of uric acid stones can be quite remarkable. Because of some of the, metabolic syndrome can also affect urinary pH. So also a lot of our patients who have diabetes and metabolic syndrome, they're also going to be more at risk for our uric acid stones. Yes, it is true that hyperuricosuria can also increase the risk, but really this is much less common. It's really going to be the urine volume and urine pH that seem to drive the stone risk for the uric acid stone patients. And that is why when it comes to managing uric acid stones, I'm really going to be focusing on increasing the urine volume and alkalinizing the urine, trying to get the urine pH up to greater than 6. And doing that with potassium citrate or sodium bicarb, depending on what's the most appropriate alkali. Very rarely am I starting allopurinol. I honestly don't think I've started it maybe at all for a stone patient. In fact, mostly what I'm doing is stopping it because it has been started by someone else and the patient's been on it for a while. And I usually end up stopping the allopurinol because even if someone has a lot of uric acid in their urine, because of the pKa, because of the alkaline, because of how much the stones will dissolve if we get the urine to be alkaline, there's really not a reason to be on the allopurinol. The focus should really be on volume and pH. Okay, so in summary, kidney stones are preventable. It's effective, it's worthwhile. Our recurrent stone formers do much better if they're followed in clinic, getting individualized tailored therapy. We can reduce not just the acute morbidity of stones, but also CKD, bone disease. We start with the supersaturation. The goal is to lower that supersaturation so that we lower their stone risk. And we very much use the 24-hour urine to direct that individualized management plan. Even if you guys don't have supersaturations, you can still look at the kind of the 4 contributors to that and identify the things that are really the lowest hanging fruit, where you can get the most bang for your buck. And I really only make 1 or 2 changes at a time because we all know human behavior. We even know it for ourselves. My concern is if I give a patient 4 things to do, they'll change 0 things. But if I can really emphasize to them how important it would be to just start with a low salt diet, let's just make that change today. We get a urine collection again in 3 months and we see how did they do. And if they made some improvement, but their urine calcium's still high, well, then we start the thiazide at that point, do a urine collection again a few, 2 months after that. And we really do it very iteratively and piecemeal until we get them down to a point where we're all, satisfied with the level of risk that they've been able to achieve. This just summarizes some of those numbers that I gave you today to remind you that, some of what our targets are for that. And thank you very much.
Thank you for that wonderful overview of the medical management of stones. So now the floor is open to questions. So please raise your hand and unmute yourself if you have any questions, and I can start the ball rolling with one. Again, playing the devil's advocate here, not necessarily because we don't have supersaturation, but what if we, give the counseling and start potassium citrate on everyone? Compared, like a dumb approach to kidney stones versus the sophisticated physiological approach. Is that good enough for a large proportion, or maybe it's not?
Well, so this has been a debate within the stone world, and there's been a couple of studies that have looked at just sort of giving blanket advice, eat a low salt diet, drink more fluid, and maybe here's a potassium or like an alkali of some sort. And so I think it was Vanderbilt, because Ryan Shee is the first author, I'm pretty sure. But so Vanderbilt and David Goldfarb was actually also on that paper. They did do a study where they looked at that, and the patients who got the tailored individualized management strategy did do better. I'm going to, of course, forget all the metrics that they looked in terms of outcomes, but this has been a source of debate sort of within the stone world, is how blanket advice versus tailored advice. And the studies, they're not necessarily perfect, but the studies that have attempted to look at that do seem to, the patients who get the individualized tailored management do seem to do better. My bias there is because it's easier. My bias there is probably that I sit there with a patient and I can say, look at your volume. Your volume is 1.5, and look at what we can, if we can get it to 2 or 2.5, look what we can do for your risk. That my bias is that motivates them more rather than just saying, oh, have a low salt diet, and they sort of follow a low salt diet. But certainly, and I wouldn't be surprised. Rock Society is next week. I wouldn't be surprised if there's at least one presentation on this next week at Rock Society, which is our stone. For those of you who don't know Rock, it's our stone, our individual stone society. And so, yes, but it's definitely been proposed, and it's not necessarily unrealistic, except for or unreasonable. But we do think patients do a little bit better with our tailored management. We're biased to think that too, though, I'll have to admit.
Yeah, I mean, we also do 24-hour urines. I was just pushing back for the sake of pushing back. Peter Magner.
Hi, that was a great talk. Can you talk a little bit about diurnal variation? Because there is diurnal variation in calcium excretion.
Yeah.
I've always wondered whether people make or grow their stones in the middle of the night, and how much should we push the glass of water at bedtime and the other one when you get up to pee at 4 in the morning?
Yeah. So yes, there's been there's a 2008, I think it was a KI paper where Fred and Elaine actually showed that yes, the supersaturation, it's exactly what we expect. The supersaturation peaks at night, and this is because even though there's going to be dietary variation in things like urinary calcium, at night the urinary calcium still stays more elevated for our calcium stone patients compared with non-stone patients. So certainly yes, their risk is highest at night. What we don't know though is, and I'll also say for that reason, there's people like David Goldfarb who, this is partially a uric acid thing, but he may have talked about when he was there a few years ago. What David does is he has people take a lot of their potassium alkali all at night. So he tries to, he like has them take a bolus of potassium alkali at night, hoping to maybe offset some of that. Again, it's a little bit more for his uric acid stone formers, but I think he does it for I think he may do it for his calcium stone formers as well. So I say all that to say that we know that nighttime is risky. Certainly, we want, in an ideal world, yes, patients would drink water throughout the night. But what we also try to balance that with is the disruption of sleep. What we don't have a straight answer for is where is that sweet spot, and maybe it depends per patient. Maybe it's an individualized thing. But I definitely have patients who get up to pee multiple times per night, and I sometimes wonder, where is that? Where is the balance there in terms of disrupting their sleep? A lot of them don't seem to necessarily mind, but we all know how important sleep is, and so I guess my answer is I don't totally know, but I think we do need to find a balance somewhere in that, and probably it's an area where we would benefit from, getting some sleep people to join us in on a study to try to better understand kind of where would we meet that sweet spot a little bit.
Yeah, sounds good. Ayub. You're muted, Ayub, sorry. Yeah.
Can you hear me?
Yeah.
Yeah. Thank you for an excellent talk. I have 2 questions and a comment. First, swap, we can do the supersaturation. It's equal to the computer program, and you can enter data into it, and it's not very expensive. Last time I looked at it, it's not prohibitive. So my question is, you do 3 24-hour urines. How far apart do you do them?
Yeah, so I tell my patients I don't really care when they do them as long as they do them. I tell them ideally one would be a work day and one would be a weekend day, and then the third one could, we talk a little bit about what their day-to-day life is and kind of try to identify which days would be better to capture that within-person variability. Some of them prefer to do it 3 days in a row, and that's fine. Some of them prefer to separate it, and that's fine with me too. My emphasis would be try to get more days that are different, and it's better to have the data than not have the data. So that's usually kind of how I default with them. These days, it's been increasingly hard to get them to do 3 beforehand. So I've started to be like, okay, as long as you do 2, then I'm okay. In follow-up, admittedly, and I might have said this, but in follow-up, I just have them do 1 because of some of the fatigue with doing the 24-hour urines, especially if I'm going to have them do it sort of iteratively then over the next several months. But yeah, I have them do, when it's the first initial eval, I tell them it can be back-to-back or different, or separated by a couple of days. No, it doesn't matter to me.
And the other question was, with resistant severe hypocytraturia, do you ever do genetic studies?
So yeah, I personally have not gotten quite on the genetic bandwagon as much as Fred would like me to. Pretty much these days, if anyone has anything subtle with their FOS, if anyone has even like, Fred has really lowered his threshold for sending some of the genetic studies. So yeah, so he would certainly sit here and say, yes, we would send someone who has severe, of course, if we think we have a pretty obvious reason why, if they have pretty severe bowel disease and we really think that that's what's contributing, then, maybe the genetic studies is less, less bang for our buck in terms of getting it. But so if we don't have a clear reason, then yes, this is where, especially in the last probably like 6 months or so, our group has become increasingly into sending genetic studies. And we also, and that's probably also part and parcel because our it's becoming increasingly easy for us to, we have a group now that like just developed a panel that we can send. So they made it easier for us in terms of sending some of these genetic studies, where our lab will actually do a lot of the work for us rather than us having to figure out how to send it off to Natera or whatever, whatever company we would plan to use and send it to. But yeah, so I think that's, I think that's where certainly the field is going to start going more and more, is sending for genetic studies.
Thank you.
Yeah.
And we have a bunch of people in the conference room. Can you go ahead?
Thanks. That was an excellent talk. I have two questions. The first is around idiopathic hypercalciuria and anti-resorptive medication. So, we don't really talk about, absorptive versus resorptive versus renal leak for hypercalciuria too much anymore. But I wonder if sometimes it is relevant. And I have had a number of patients over the years. In fact, I had one yesterday with osteopenia or osteoporosis and hypercalciuria, no primary hyperpara. And the question always comes up in my mind, and I haven't been able to find anything in the literature, and in my experience, I don't know the answer to this. Does anti-resorptive therapy reduce urinary calcium in patients with osteopenia and hypercalciuria? Are you aware of any evidence that would help answer that question?
There is, so the short answer is no, I don't really, and that's partially because, a lot of that, as you point out, a lot of the thought about the, the hyperabsorption and what's going on in the gut, a lot of that has fallen quite out of favor. And so the thought is that it's not contributing nearly as much, or that kind of the dichotomies that were set up there are probably not as present as it was thought, several years ago, or at this point, maybe on the order of a couple decades ago. So yeah, the short answer is not really. What we really focus on for those patients is thinking about what their balance of their intake is versus their output, to try to make sure that they're not in negative calcium balance. And then also thinking about, some of the simple things of making sure, all the things we would do for our CKD patients, making sure that there's no, systemic acidosis, all of those things are in, which of course you would be doing anyway. And then, trying to manage all their other risk factors. And then if they need a bisphosphonate or something, something else to help support their bone disease. And we do have that bone disease paper that I showed we did look at bisphosphonates, and we did see that patients who were on bisphosphonates actually did have lower stone risk as well. The 24-hour urine data didn't necessarily pan out in terms of changes in 24-hour urine. That might have been just that we had not enough people on it. But so the short answer is no, I don't really, but we do all the things you probably, for that type of patient, we would do all the things that you're already, considering and probably doing.
And second question, if I'm allowed, is we all have refractory stone formers. I mean, they tend more to be maybe the brushite than the calcium oxalate. And there's really interesting data in PKD about tolvaptan and significantly reduced lithogenicity of their urine, and the tolvaptan studies seem to show fewer stones in PKD patients. Are you aware if anybody's doing any clinical trials using tolvaptan in refractory stone formers? Because to me, that seems to be kind of a reasonable last-ditch thing to look at.
Yeah, so I know that at ASN, it was one of the in-person ones, and it was a couple years ago, so it might have been like DC, that I remember someone definitely had a poster. It was a poster presentation where they'd given, I think it was the Mayo folks, I can't remember who it was, but they definitely gave, I can't remember if they gave I think they actually gave stone formers tolvaptan. I don't really remember what the result was, which probably means it was either null or they had enough issues with it, or maybe because it's cost prohibitive. It certainly, I think it's a great idea. It has not picked up in terms of, anything that the stone world really talks much about. I will say, however, though, there's increasing buzz with all diseases, but also with stones for SGLT2 inhibition. And so I think that both of those are probably things we need to continue to consider, especially as hopefully things like the Vaptans come down in terms of cost. And certainly it'll be interesting as we learn more about SGLT2 inhibitors. There's been a couple of studies where they've not necessarily in stone formers, but a couple where they've looked at the urine composition and we can get a little bit of a sense of what changes we might expect from a urine composition and how that might translate to stone risk. So the SGLT2 inhibition has come up. That has been coming up in our lab meetings a little bit more, and I think we're even probably going to put in a grant that includes an aspect of it. We haven't included the tolvaptans, but I think that that's something, certainly is interesting. I should go back and try to find that abstract. Maybe ask the people at ROC next week, kind of remind me what they had done with that, because I certainly think it's interesting. And to your point, yeah, we have Arlene Chapman here is big in PKD, and so she has, she gives tolvaptan out all the time and like water, and so certainly there's good precedence in the PKD world about tolerance and all that. So.
Thanks.
Yeah.
Greg.
Yeah, thanks, Megan. It was a great talk. So my question was kind of the recurrent stone formers in terms of what's your practice in terms of long-term follow-up once they've actually implemented some of the changes and you're happy with it.
Yeah.
Do you continue to follow them, and like how frequent do you continue to follow their 24-hour urines to see if they're consistent or if things have changed over time?
Yeah. So a lot of times, once the last couple of weeks, I've kind of seen a couple of patients who are falling into this category. So a lot of times what I'll do is once we hit that point, like last week I saw this woman, we finally got our supersaturation down to 3. We got our urine calcium to a point where we were both really happy. Her stone risk was low. And so I said to her, we can either see each other in 6 months with a urine, keep doing what you're doing, don't make any changes. We can do it in 6 months, or we can do it in 12 months. And she said, I want to do it in 6 months because I want to make sure that I'm like having that extra, the extra push to make sure I'm still doing it and not, have it go. So early on, right after I'm kind of graduating them from like the every 2 months or every 3 months urine collection, I do probably either 6 or 12 months or maybe 9 months, depending on, what I think what changes I'm requesting of the patient or recommending the patient, and what, how, when together in terms of discussion with the patient, we think it'd be appropriate to check it again. And then it's probably reasonable for some of the people who have really showed stability to do it once a year with a single 24-hour urine to make sure we're in the right place. Our urologist, when he follows with our stone patients, he usually does every 6 months or every year with repeat imaging. So I sort of follow that cadence as well. Like once a year, get him in 24-hour urine and probably ultrasound with urology around the same time. Looking good, see in a year.
Thank you. Yeah, it seems like a good measure to ensure compliance. Peter wants another question.
Yeah, or maybe 2 very quick ones. A bunch of times see people with women, typically with osteopenia and stones. And of course, their family doc has put them on vitamin D and a calcium supplement.
Yeah.
And I always think and if they have hypercalciuria, I always think the vitamin D must be increasing that. So can I win when I tell them to stop their vitamin D?
So yeah, so a couple of things there. Usually what I'll do is just check what their vitamin D level is. If their vitamin D level is adequate, then usually I stop the vitamin D. If it's low though, there was a trial. So David Leaf was the first author, and David Goldfarb was on it. It's a couple of years ago now that it was published. I think David Leaf was even a fellow, so it was probably several years ago by now, where they actually took idiopathic stone patients who I believe are hypercalciuric, but they had low vitamin D, and they gave people ergo for I think it was an 8-week course, and they didn't at the end of the trial have any big differences in any of the parameters that we would look at for increasing risk. So the conclusion there is when someone is vitamin D deplete, it is probably safe to replete their vitamin D. But yes, certainly if their vitamin D stores are adequate, then I would probably stop their vitamin D, but just routinely check it. And then with the calcium supplements, usually what I'm going to say instead is, let's get it with your diet, let's get you to the dietary calcium. Let's put it in yogurt. Let's put it in your milk, get it in the dietary form rather than supplement form.
Yeah. So of course there are controversy about how adequate vitamin D levels and which threshold are you going to use and all true. That. And I, in line with what Brendan said, would tend to try to make them take a bisphosphonate, which might reduce calcium coming out of bones, even though we don't know vitamin D. And your last point, why diet rather than taking calcium carbonate? Because we use calcium carbonate as a phosphate binder. isn't it an oxalate binder as well? Why don't we use Tums to decrease the urinary oxalate?
I mean, I think that I think if they are going to eat it with their meals, then sure, that's fine. If they don't really like yogurt, they're lactose intolerant, and they want it, and we think that the best way to get them their adequate calcium is in a tablet form, then I would just say eat it with your meals, eat it with breakfast, eat it with dinner. Yeah. So no, that's a very fair point. The same way we would with our our ESRD patients. Yeah. Yeah.
Fantastic. And it's 9 o'clock, so I think we should wrap it up and let you go back to your clinic. We hope you.
I forgot to ask about the sulfate.
We hope you get. Do you have another question, Brendan?
Just very quickly, and so John is our dietitian who talks to all of our stone patients. And one thing I'd been wondering about adding onto our stone profile, and you do it, is the 24-hour urine sulfate as a marker of animal protein intake.
Yeah.
Does your dietitian find that helpful to have that? Because we know that sulfate mostly comes with animal protein, and that's what we're mostly telling the patients not to eat. A total urea just tells you about your total protein intake.
Yeah, we use it all the time. We use it not just as a marker of animal protein, but we also use it because I use it when I'm looking at acid-base status and trying to better understand their acid-base status. I'll compare the sulfate and ammonia and we expect the ammonia to be
one, yeah,
2/3 of the sulfate. And so I use those very much together. And so, yeah, I would definitely, I look at it on every single 24-hour urine that I get. Even I look at it even on the patients where it's like really straightforward, just like, okay, they need to drink more. I still look at all the other parameters, just if nothing else to nerd it out a little bit. But yeah, we look at it on all of our patients. Yeah.
Thank you.
Yeah.
Fantastic. Thank you again for that wonderful overview, and yeah, hope to catch you at the ASN or some other meeting in person.
Yeah. Yes. Thank you all so much. Thanks, Greg.